I'm Dr. Paul Shyn. The topic today is imaging of hepatocellular carcinoma, and in particular using LI-RADS for HCC. The incidence of hepatocellular carcinoma worldwide places it at about number 6 in terms of frequency. Mortality rate is high though, and so HCC is the number 2 cause of cancer death worldwide. In the United States, the statistics are a little bit different. HCC was rapidly increasing in incidence over the last 3 decades. It was probably the most rapidly rising cancer in terms of incidence. However, with the development of antiviral treatments for hepatitis C, which was the main driver of the epidemic in the Western countries, the incidence is stabilizing. On the other hand, metabolic syndrome and fatty liver disease are now sort of driving and maintaining the incidence of hepatocellular carcinoma in the West. The survival rates for hepatocellular carcinoma have actually been improving, and that's multifactorial. One is the adoption of effective screening programs for HCC, so we're picking up the disease earlier. Also, better local treatments and surgical treatments for HCC, and even now some systemic treatments that are impacting the disease. Because of improved treatments for hepatocellular carcinoma, 5-year survival rates are now in approximately the 40 to 70% range. Let's take a look at a case. This is a 59-year-old male with cirrhosis from chronic hep C, and if you look at the imaging, we see a subtle T2 hyperintense mass, mildly T1 hyperintense. There's definite arterial phase hyperenhancement, and then we do see washout, meaning that the mass de-enhances more than normal liver. And we also see a capsule appearance. So if you've been on the abdominal rotation, you know that this would be a classic LR5 or LI-RADS 5 lesion. So what is your recommendation? Do you recommend a biopsy? Do you recommend treatment? What do you do? Well, the answer usually is that we treat this as an LR5 as diagnostic of HCC, and we proceed to make treatment decisions based on that diagnosis. And if you think about it, that's completely unlike the way we approach virtually any other cancer. Oncologists always want a tissue diagnosis before committing to a treatment regimen. Why is it different for HCC, and why do we have LI-RADS? First of all, what is LI-RADS? So LI-RADS stands for Liver Imaging Reporting and Data System. And it is basically a set of diagnostic criteria and terminology that have been standardized for the reporting of liver imaging tests in patients who have an increased risk of HCC. It was developed by the American College of Radiology in 2011, and there have been a series of updates, most recently in 2018. Why was LI-RADS developed? LI-RADS was developed because there was a perceived need to avoid biopsy in making the diagnosis. This stemmed from a few things. One is that historically, it was not that unusual to have a false negative biopsy for HCC, particularly if it was well differentiated. Sometimes pathologists had a bit of a hard time distinguishing normal liver from hepatocellular carcinoma. I would say that's less true today, but historically that was sometimes an issue. The second thing was that biopsies of hepatocellular carcinoma carried an increased risk of bleeding complications, and more importantly, tumor seeding, either along the biopsy tract or into the peritoneum. That, of course, disseminated the disease and had an impact on the potential for cure. A third factor was that histopathology findings, the stains, the biomarkers, none of these that were observed on pathological analysis had any impact whatsoever on the treatment of hepatocellular carcinoma. If you had a very poorly differentiated hepatocellular carcinoma, your treatment was the same as if you had a well-differentiated tumor. There may have been some difference in prognosis, but no treatments were stratified based on histopathology or tumor markers. The other thing is that it was noticed that imaging was often quite accurate in making a diagnosis of hepatocellular carcinoma. And so there became this great interest in making the diagnosis based on imaging, particularly in patients who were about to undergo liver transplant, so as to avoid the risk of tumor seeding and bleeding. Unfortunately, what happened over time was that many of the patients who went to liver transplant because of presumed HCC, about 20% were found to not actually have HCC on explant pathology. So this drove the need for better specificity in the imaging of HCC, so that when we called it HCC, there was a very, very high probability, a high specificity that it would in fact be HCC. Is LI-RADS a staging system? The answer is no. TNM is a staging system based on pathological information, the size of tumors, the presence of extrahepatic disease, and so on. And then there are also clinical staging systems, notably the BCLC or Barcelona Clinic Liver Cancer Staging System, which links the stage of the disease with liver function, patient performance status, and treatment options. LI-RADS itself, though, is strictly an imaging diagnosis probability algorithm. So let's look at another case. Here you see a liver mass that's markedly T2 hyperintense. And then after contrast administration, we see this peripheral nodular enhancement that gradually progresses centripetally. And then, of course, because this is gadoxetate disodium or Eovist, at 30 minutes there's no retention of contrast in this mass. This is diagnostic of a benign cavernous hemangioma. We would categorize this as a LI-RADS 1. And so now I've shown you a LI-RADS 5 mass and a LI-RADS 1 mass. So these are opposite spectrums of our LI-RADS scale, LR1 being certainly benign and LR5 being almost certainly HCC. The other categories, LR2, LR3, LR4, fall in between these two in terms of probability of HCC. LI-RADS 1 carries virtually a 0 probability of HCC. LI-RADS 2 also virtually 0. LI-RADS 3, however, is sort of intermediate, and it's about a 1/3 probability of HCC. LI-RADS 4, depending on who you read, it's about 2/3 to 3/4 of these LI-RADS 4 masses will turn out to be HCC. And then LI-RADS 5 is hopefully 95% or greater probability of HCC. Here we see another example of LI-RADS 1 lesions. These are classic simple cysts, very bright T2, very sharply demarcated. Of course, there's no enhancement. And so all of the categories, the LI-RADS categories from 1 to 5, essentially reflect probabilities of HCC. And the major features, there are 5 major features that we will talk about, are the major drivers, of course, of how we categorize these lesions. And for LI-RADS 5, which demands the highest specificity, we only use major features to make that call. This chart is what you do 95% of your work with when you're using LI-RADS at the console. And notice that this chart will be used to assign scores of 3 to 5. This chart really is not used for categories 1 to 2, other than to say that they don't fit into this table. Again, there are 5 major features reflected on this table. Across the top, you can see that the most important feature is arterial phase hyperenhancement, and specifically that's non-rim arterial phase hyperenhancement, and we'll talk about that more later. And then the second most important major criteria is the size of the observation. This falls into 3 categories: less than 10 millimeters, 10 to 19 millimeters, and at least 2 centimeters or larger in size. Obviously, the larger a mass, the more likely it is to be malignant or to be hepatocellular carcinoma. Lesions that are less than 10 millimeters in size certainly may be hepatocellular carcinoma, but the imaging criteria that we use to make a diagnosis of HCC become less reliable in these very small lesions. So notice If you start with arterial phase hyperenhancement, to get an LR5 score, which is diagnostic of HCC, you have to have non-REM arterial phase hyperenhancement. That's the sine qua non of an imaging diagnosis of HCC. However, that is not sufficient. You also need other features. So, for example, if the lesion is larger than 2 centimeters and you have arterial phase hyperenhancement, then you only need one other major feature listed on the left, either an enhancing capsule, non-peripheral washout, or threshold growth to make it a LI-RADS 5 observation. The LR4 are lesions that are either smaller or have fewer major features, LI-RADS 3 even less. Notice that if the lesion does not have arterial phase hyperenhancement, the highest score that you can assign is LI-RADS 4. That doesn't mean that it's not HCC, it just means that we can't give it a highest probability of HCC. Let's take this example. Here we have a patient with cardiac cirrhosis. We did a multiphasic CT. Clearly there's arterial phase hyperenhancement, and on the delayed imaging we can see washout greater than background normal liver, so we do see washout. The observation measures more than 2 centimeters in diameter. So how would you categorize this? If you look at the table, you might say, okay, this measures more than 2 centimeters, it has non-REM arterial phase hyperenhancement, and it has washout, so it has one of these other major features. That should make it an LR5. However, I mentioned that this is cardiac cirrhosis. It turns out that cardiac cirrhosis is not considered a high risk factor for HCC. It doesn't mean that you can't get HCC with cardiac cirrhosis, but the imaging diagnosis is much less reliable in patients with cardiac cirrhosis. So we don't use LI-RADS in patients with any vascular cause of cirrhosis. So what are the risk factors that in which we can use LI-RADS? It applies to patients who have cirrhosis, chronic hepatitis B, or a diagnosis of HCC already, either a current diagnosis of HCC or prior diagnosis of HCC based on pathology. But there are some exceptions, and that is if the patient is younger than 18 years of age, we cannot apply LI-RADS, or if their cirrhosis is due to congenital hepatic fibrosis, or if it's due to vascular etiologies like congestive heart failure, then we cannot apply LI-RADS reliably. And again, they may be at increased risk for HCC, but it's just not enough that we can have confidence that a LI-RADS 5 in these patients has a 95 or greater percent probability of HCC. Let's look at another case. Here we see a T2 hyperintense mass in the liver. On in and out of phase, the mass contains lipid and drops considerably on out of phase imaging. There's clearly arterial phase hyperenhancement, there's washout, and even a capsule. So this should be LI-RADS 5, except for one problem. This was not a cirrhotic patient. There was no chronic hepatitis B. This was a young woman who had a history of taking birth control pills, and this was simply a liver adenoma. So the imaging features of benign hepatic adenoma can be virtually identical to that of HCC, and so the risk factors become critical in applying LI-RADS in these patients. Of course, HCC does occur in the absence of cirrhosis. Depending on the study you look at, about 10 to 20% of HCC tumors occur in the absence of cirrhosis. About up to a third of these might be fibrolamellar HCC tumors. A significant percentage are patients with chronic Hep B. But increasingly, many of these patients with HCC in the absence of cirrhosis are patients with non-alcoholic fatty liver disease or metabolic syndrome. Very important and rising in incidence in the United States. Note that LI-RADS can be used with both CT and MRI examinations as long as they're completed according to protocol. LI-RADS does allow for the use of extracellular contrast agents or hepatobiliary contrast agents such as Eovist. remember, do not assign a LI-RADS category for any observation which has already been path proven. If it's been path proven, it makes no sense to apply a LI-RADS probability score. For untreated observations, then, these are the possible categories that we will apply to what we see. Notice that there's a category called LRNC, not categorizable. It's important to understand that this does not mean that it's indeterminate based on imaging findings. Instead, what this means is that the imaging was either insufficient or non-diagnostic. For example, maybe we were missing an arterial phase scan, maybe there was motion artifact, there was a technical problem that precludes the application of LI-RADS. And so you'll just make a recommendation for appropriate alternative imaging or some other appropriate workup to make the diagnosis. And then we have the LR1 through 5 categories to assign the probability of HCC. Notice there's an LRM category that is likely malignant but not necessarily HCC. For example, it could be a cholangiocarcinoma in a patient with cirrhosis, and we'll talk more about that. And then there's LRTIV, or tumor in vein. This is very important because it has major implications for treatment options. For example, transplant is rarely considered in a patient who has tumor in vein, since their likelihood of recurrence after transplant would be high. So you may have heard of a MELD score. This stands for Model for End-Stage Liver Disease. The idea of the MELD score is it's an indicator of the probability of death from liver disease within 3 months. Patients who get placed on a liver transplant list all end up being assigned a MELD score, and it's often calculated based on a formula that takes into account the serum creatinine, bilirubin, INR, and sometimes sodium level. The maximum MELD score is 40. The higher your score, the more likely you are to die within 3 months of your liver disease. The MELD exception points are assigned for various other conditions that increase your eligibility for a liver transplant. For example, hepatocellular carcinoma is one of these conditions that will increase your priority for liver transplant potentially if you meet certain criteria. If you meet the criteria, you'll be assigned a MELD score of 6. Then you'll get another 6 points for your first extension. I think that's at 3 months. And then for your second extension or beyond, you'll get a score that's 3 less than the mean MELD at transplant for the region. So they take a look at all the patients who received a transplant in the region and figure out what the median was, and then subtract 3 from that to get your MELD exception points. And the longer you are on the waiting list, your exception points also tend to increase. The details are not that critical to understand. They actually seem to change quite regularly, but the concept is that you can get prioritization for liver transplant in part because of having a diagnosis of hepatocellular carcinoma, as long as you don't exceed certain criteria that we'll talk about. Now, over the years, there was some concern because liver transplants were being done quite frequently for patients with HCC. So there was concern that it was prioritizing too many patients. At one point, almost 20% of liver transplants, for example, in 2015, were going to patients with HCC. And this was felt to be disadvantaging other patients with different causes of liver failure. So they kind of made the criteria more stringent for people with HCC. And as a result, management of HCC with local therapies or surgery assumed even greater importance than it already did. Imaging, of course, throughout all of this remains critical to management because it determines what treatment options are available. Do patients qualify for MELD points? Can they get a transplant? And so on. You may know that OPTN, which is the Organ Procurement Transplant Network, has its own specific criteria for the imaging diagnosis of HCC. It turns out it's quite similar to LI-RADS in terms of LI-RADS 5 category. However, there are quite a few differences. It's helpful to understand what the differences are and what that means for you. LI-RADS in many ways is a more comprehensive scheme that takes into account all observations that you might see in the liver, from the most benign to the most malignant and those that are most likely to be HCC. It really stratifies the risk of HCC along this spectrum, whereas OPTN is really focused on is there HCC or not. They just want high specificity for a diagnosis of HCC. Because LI-RADS is more comprehensive, it's really helpful for all management and therapeutic considerations short of liver transplantation, but including liver transplantation. So, for example, just because a patient isn't an OPTN or LI-RADS 5 doesn't mean that they don't need treatment or management. The intermediate scores can help guide the management decisions. If you happen to work at a liver transplant center, and technically Brigham and Women's is a liver transplant center because we're part of Mass General Brigham and the liver transplants are done at Mass General, OPTN scores are generally required. If we don't assign an OPTN score, it will be overread at Mass General, for example, and they'll assign an OPTN score. From what I understand, there are some liver transplant centers that will use LI-RADS scores, and for the most part, LI-RADS 5 is the same as OPTN 5, but we'll talk about some of the subtle differences. OPTN criteria do not specify the option of using extracellular gadolinium contrast agents. That doesn't mean that they don't accept it, but it's just not actually spelled out. They basically require cirrhosis of any etiology to apply OPTN criteria. They don't specify beyond that. And you might ask, well, why would they do that? One reason is that if you think about it, liver transplantation has always been really about treating patients who are moving into liver failure. And it wasn't really primarily designed as a treatment for cancer. It's more about liver failure. The flip side of that is that if you have liver cancer and don't have cirrhosis, you may very well be a surgical candidate for a partial liver resection. So you wouldn't have to have a transplant in that case. You would just go to liver resection. But above all, OPTN is focused on a high specificity categorization of lesions in terms of HCC. Here's another patient, a man with alcoholic liver cirrhosis. On pre-contrast imaging, it's really hard to make out a focal abnormality. On arterial phase, there's clearly a 2.2 centimeter arterial hyperenhancing lesion. And then on later phases, really can't say that we see washout or a capsule appearance. So what do we do with this mass? Well, we can look for ancillary features, and maybe there's a subtle T2 correlate, really hard to call. I probably wouldn't call it. There is restricted diffusion, but fortunately we had a comparison study. So 3 months ago, the patient had an MRI, and the lesion measured only 14 millimeters in diameter. Now it measures 22 millimeters in diameter, so that's a greater than 50% increase in diameter in less than 6 months. So that means that we have threshold growth. So now we have an arterial hyperenhancing lesion that's over 2 centimeters in diameter with threshold growth. That does meet criteria for LR5. And notice that the criteria for threshold growth between OPTN and LI-RADS are now identical. This, on the latest version, was made congruent. This increases our sensitivity for any malignancy, including HCC. And just a reminder that we did not use the ancillary features to make this an LR5 because we are not allowed to use ancillary features to go from an LR4 to an LR5. That's why we had to look hard for the other major feature of threshold growth before we could make this an LR5. These are the ancillary features that LI-RADS lists for favoring malignancy, favoring HCC in particular, or favoring benignity. I'm not going to go through all of these, but these are the ancillary features that we would look for. It's important to know that ancillary features can be used to upgrade from a lower category to a higher category, but not to an LR5. LR5 categorization can only be based on major features. You can downgrade an LR5 to an LR4 and so on, but you can't upgrade to an LR5 with ancillary features. Now notice that if you have 1 or 5 ancillary features that favor HCC, you only can upgrade one category. Similarly, if you have 1 or many features that favor malignity, you can only downgrade one category. Notice that if you have any combination of opposing ancillary features, whether it's 1 favoring HCC and 5 favoring malignity, they just cancel each other out. So any opposing ancillary features cancel each other out and we don't use them. Another alcoholic cirrhotic with a 5 centimeter mass in a 51-year-old male with Hep C, and the AFP level is 22,000. So on T2, there's a subtle T2 hyperintense mass. On pre-contrast, we can see that the mass is predominantly hypointense, although there may be some internal areas of hyperintensity. There is no arterial phase hyperenhancement, but we do see a capsule that enhances and persists. There is restricted diffusion. So what would be the LI-RADS class here? We have lack of arterial phase hyperenhancement. So remember, that is the one feature that has to be present for an imaging diagnosis of HCC. So it cannot be an LR5, but it is a large mass, larger than 2 centimeters. It does have a capsule. The capsule makes it an LR4. And then restricted diffusion is an ancillary feature, but we can't increase to LR5 with an ancillary feature. So we're kind of stuck at an LR4. So this brings us to the frequency with which we use ancillary features. It is considered optional. You don't have to use ancillary features. The main reason for this is because you're not going to use it to upgrade to an LR5. But on the other hand, ancillary features may improve our sensitivity for HCC, but ancillary features may impact our classification, particularly going from LR3 to LR4 or LR3 to LR2. This is relevant in that it may impact our management decisions about how to manage patients short of a definitive diagnosis of HCC. Here we have a patient, a 75-year-old with a history of lung cancer that was resected a few years ago. She's disease-free, but she does have chronic hepatitis and cirrhosis and now concerned about HCC. The mass lesion that we see is subtle, really not well visualized on non-contrast T1 weighted imaging, very slightly hyperintense on T2. There is arterial phase hyperenhancement, there is washout and a capsule appearance, but the lesion is only 1.5 centimeters in diameter. While this does qualify as an LR5 mass in LI-RADS, what would be your management decision? Would you do ablation as a bridge to transplant? And the answer is no, because lesions less than 2 centimeters in size, even if they are LI-RADS 5, or in OPTN it would be considered OPTN 5A, as a single lesion, that does not earn you MELD points. And if you ablate this lesion, the patient will never get exception points for transplant. And so if the patient is considered a transplant candidate, you want to avoid doing an ablation before the mass gets to be 2 centimeters in diameter. It's one of the paradoxes of the OPTN criteria and the liver transplant policy, but they don't like to make a definitive diagnosis of HCC in a single mass unless it's at least 2 centimeters in size, mainly because of the decreased reliability of imaging in lesions that are progressively smaller. So when we look at the size of a tumor, it's very important to be careful with observations that are less than 2 centimeters in diameter. Keep in mind that lesions smaller than 1 centimeter will never be called an LR5, and they are not assigned an OPTN class. And again, this is because with these smaller lesions, imaging is felt to be less reliable. So the maximum score in LI-RADS that we can ever give to a lesion less than 1 centimeter is LR4. That still means that it's likely HCC, but we can't give it an LR5. If you have a tumor that's at least 1 centimeter in diameter but less than 2 centimeters, the maximum LI-RADS score is 5, which would be an OPTN 5A. But again, as a single lesion, that doesn't qualify for exception points. And then for patients that have larger single lesions, for example, if they have one tumor that's between 2 and 5 centimeters in size that meets imaging criteria for HCC, that would be a LI-RADS 5, and it would be an OPTN 5B lesion. These would qualify for exception points based on imaging. Again, if the lesion is less than 2 centimeters, don't ablate it if transplant is being considered. At least have the transplant team evaluate the patient before any decisions are made. The other thing that's increasingly recognized is that treatments other than surgery or transplant may be just as effective or even more cost effective for treating very small HCC tumors. For example, the outcomes in patients with single HCC tumors less than 2 centimeters in diameter or up to 2 centimeters in diameter is virtually identical for ablation and surgery. There's a growing body of evidence supporting that. If we compare the LI-RADS table and the OPTN categorization, it looks something like this. I put the LI-RADS table on top and I created this OPTN table on the bottom. And notice if there's no arterial phase hyperenhancement, then the lesion simply doesn't get an OPTN class. They're only interested in lesions with arterial phase hyperenhancement. So that's a major difference between the two. The second thing is if the lesion is smaller than 10 millimeters in diameter, there's never an OPTN class. So they're essentially not interested in lesions less than 10 millimeters in diameter. If the lesion is 2 to 5 centimeters in diameter, then a LI-RADS 5 lesion is essentially always equivalent to an OPTN 5B, and that would qualify a patient for exception points, assuming it's a solitary observation in the liver. If the lesion is 10 to 19 millimeters in diameter with arterial phase hyperenhancement and threshold growth, then an LR5 is equivalent to an OPTN 5A-G, and this could contribute to exception points if the lesions are multiple. If the lesion or observation is 10 to 19 millimeters in diameter with arterial phase hyperenhancement, a capsule and washout, then an LR5 would be equivalent to an OPTN 5A, which again would qualify for exception points if the lesion is multiple. If the observation is 10 to 19 millimeters in diameter with arterial phase hyperenhancement and washout, but no other major features, then an LR5 is not equivalent to an OPTN 5A. So a 10 to 19 millimeter mass with arterial hyperenhancement and washout only, but no other major features, does not qualify for exception points. Whereas LI-RADS does not take into account clinical features and does not take into account, for example, AFP level, OPTN does have an interest in what the AFP level is, and they require it to be less than 1,000 at the time of diagnosis. Then if the patient undergoes local regional therapy, the target is to get the AFP under 500 and to remain under 500 until transplant. So we talked about Milan criteria. Milan criteria are a single tumor 2 to 5 centimeters in size, or 2 to 3 tumors that are between 1 and 3 centimeters in size. But increasingly, UCSF criteria or more liberal criteria are allowed if the patient can be downstaged back to within Milan criteria. So, for example, if you have a single tumor that measures up to 8 centimeters in diameter, and if after local therapies that is brought down to 5 centimeters or less, then that patient might still be eligible for exception points. If they have multiple tumors, 2 to 5 tumors, if their combined diameters do not exceed 8 centimeters, they are often eligible for downstaging if they can be brought within Milan criteria. What is the role of biopsy? For LR5 observations, imaging features are the basis for classification and management, and generally no biopsy is indicated. This is especially true if the patient is being considered for surgical or transplant as a curative option. The main advantage is this avoids tumor seeding or false negative biopsy issues. For patients with LR4 or LRM observations, biopsy may be helpful in ruling out or confirming a diagnosis of HCC. In certain circumstances, as we mentioned, the path diagnosis may contribute to MELD exception points. Biopsy of a solitary tumor less than 2 centimeters in size, even if diagnostic of HCC will not enable the patient to qualify for MELD points. On the other hand, if the mass is 2 to 5 centimeters in diameter, showing arterial hyperenhancement but no other major features, a biopsy is accepted by OPTN to make the diagnosis and generate exception points. Only if there are 2 to 3 observations, then biopsy of a 10 to 19 millimeter arterial enhancing lesion may also be acceptable. This is an example of a patient with 2 observations that range from 1 to 3 centimeters in diameter. They both demonstrated arterial phase hyperenhancement and washout with a capsule. And so this would be diagnostic of HCC, and ablation would be allowed because there are 2 lesions, even though both are smaller than 2 centimeters in diameter. If you do a biopsy to make a diagnosis of HCC, please, whatever you do, find a way to get to the mass by going through uninvolved liver. You do not want to directly puncture a subcapsular HCC. The bleeding risk is greater, and the risk of tumor seeding into the peritoneum is not insignificant. So choose a path that takes you through at least a couple of centimeters of normal liver whenever possible. Right now, I think we're sort of in the waning days of avoiding biopsy of HCC tumors. The reason for this is that while an imaging diagnosis of HCC is often possible, the importance of histopathology, genetic sequencing, other biomarkers is going to become increasingly important. We are now in the era of immunotherapy for HCC. There is tremendous research interest in better characterizing HCC tumors and correlating this with therapeutic options and therapeutic outcomes. And I think that we're going to, in the next few years, observe a shift back towards more routine biopsies of hepatocellular carcinoma. Right now, while we're avoiding biopsies in many cases, that trend is going to reverse. So how well does LI-RADS perform compared to OPTN5? How well does a LI-RADS 5 categorization compare or perform to an OPTN5 categorization in terms of sensitivity and specificity for HCC? In general, when you look at the literature on this, the sensitivity of LI-RADS for HCC is virtually always at least as good or slightly better than OPTN5 in diagnosing HCC. However, specificity is often more comparable or even slightly greater for OPTN5. And again, this reflects the fact that OPTN was really structured from the very beginning to be highly specific, so that when they took a patient to transplant, based on an imaging diagnosis, they were fairly certain it would really be HCC. Let's look at another case. Here you see a mass that has a lobular contour. When contrast is administered, there is progressive enhancement in sort of a band-like pattern that progresses into the later phase. Notice that there's this thin outer rim of washout. If you squint, there are some areas where you might see subtle arterial phase rim enhancement in the early arterial phase. And then on T2, the coronal image, you can see that there are vascular structures coursing through the mass without being occluded. And then above the mass, we see some dilated bile ducts. So this is a classic appearance for cholangiocarcinoma with the progressive enhancement. Cholangiocarcinomas do show arterial phase rim enhancement, rim washout, and that's why when they set up LI-RADS, they said that the arterial phase hyperenhancement and washout cannot be rim-like because that's typical of cholangio. And I always feel that Cholangiocarcinomas look a lot like geodes when you see these in natural history museums because of this lobular shape, this sort of laminated pattern of density differences and enhancement. Cholangiocarcinoma is, of course, the second most common malignancy in patients with cirrhotic livers. It would be classified as LRM, meaning likely malignancy, but not specific for HCC. And other LRM masses might turn out to be metastases or lymphoma. You do not get MELD exception points for an LRM classification, and this would certainly be an indication for a biopsy. For example, we also see tumors that are mixed HCC and cholangiocarcinoma. So if you look at this patient who had diabetes, we see these arterial phase hyperenhancing masses. And then as you go into later phases, the one that's sort of more central shows persistent enhancement that does not wash out, whereas some of the other masses show very distinct washout and capsule appearance. At biopsy, this indeed turned out to be a mixed HCC cholangiocarcinoma. So this is one of the more spectacular examples of the mixed type pathology, and that's observed in about 5% of HCC tumors. When you see this, it was always puzzling to me why we would have patients that have tumors that have both features of cholangiocarcinoma and HCC. But the current thinking is that these tumors really are not arising from mature hepatocytes and mature bile duct epithelium, but rather these are tumors that are arising from more primitive like stem cells in the liver that become malignant, and they differentiate in variable ways. They can differentiate more like hepatocytes into a hepatocellular carcinoma, or more like biliary epithelium into a cholangiocarcinoma, or a mixture. We definitely see this in about 5% of cases. And if you establish this diagnosis pathologically, these patients do not get MELD exception points, and they are treated more based on their cholangiocarcinoma histology than their HCC pathology. The same patient has tumor extending into the IVC, so this would be LRTIV. Again, that's a very important observation to make because it impacts treatment. These patients who have vascular invasion are generally not considered transplant candidates because of the very high risk of recurrence. To call TIV, you need to see unequivocal enhancing soft tissue within a vein, with or without a parenchymal liver mass. Like all findings that we assign in LI-RADS, if you are unsure of the finding, don't call it. While tumor in vein is seen more commonly with HCC than other malignancies, it is also seen with cholangiocarcinoma and other malignancies in the liver. With all major findings in LI-RADS, if the finding is equivocal, do not call it. The accuracy of LI-RADS is predicated on major findings being definitely present. If you're equivocal about whether or not the finding is present, don't call it, because you'll be decreasing your accuracy or your specificity, particularly for LR5 findings. So that wraps up our discussion of LI-RADS and imaging of HCC. We didn't cover everything, but I hope this gives you a good overview of where we are with LI-RADS. Thank you.